value. So that's not just us telling people what to do, it's working with people to create solutions. So working with communities and stakeholders, and social marketing is about integrating research, practice and theory as well. And a really important part of social marketing is that it's theory driven. And it creates effective, ethical, equitable, sustainable social change solutions that tackle complex social problems, health, economic and environmental challenges. So social marketers work across a broad range of contexts. So not just health, but other social issues, whether that's domestic violence, for example, human trafficking. We also work, I don't, but other social marketers work in economic social change as well. So things like financial literacy and environmental challenges. So, some of the projects at Social Marketing Griffith that we have worked on and continue to work on is koala conservation, for example. So reducing dog attacks on koalas, which is a big problem. And a range of other things, getting people to change their fishing practices. So fishing less of more endangered species, for example. So a whole range of issues. We've done work on washing hands. I led a piece of work in Malawi on hand washing behaviours in primary schools, for example. So we do a whole bunch of different things. But it's really using those marketing techniques to help people to change their behaviour. And it operates not only at the individual level, but in the systems level as well. So we, use a range of different terms, but for example, upstream social marketing, midstream social marketing, and downstream social marketing. So I'm sure that many of you are familiar with the upstream, midstream, and downstream approach. So that's very much what social marketing does. So it, might be to advocate for policy change, for example, or it might be helping people to actually change their behaviour through improving their self-efficacy or self-confidence in cooking healthy meals. Oh, there we go. That's on clicking 50,000 things. Oh, that's fine. So how, what are some of the ways that we can use marketing insights for positive behaviour change? So as there's some benchmark criteria for social marketing. So it's very much a systematic approach and process-driven approach. So it's all about consumer insights. So really listening to people to understand what it is they want and need to help them change their behaviour or keep their current behaviour, for example, or it might be to reject a behaviour. So if we think about, the vaping issue at the moment, we want people to not do that or never take that behaviour up. So sometimes it's about rejecting behaviour. So not just adopting or adapting with behaviour, but also rejecting behaviours. We look at the competition. So, all of these lovely marketing concepts. So looking at the barriers and facilitators. So that might be a term that's more familiar to you. So thinking about what actually competes for our priority groups, time, effort, money, what might be stopping them from participating. And that could be, other organisations, like McDonald's advertising very cheap food for them. Segmentation, so actually breaking down what, that priority group into smaller bite-sized groups, I suppose, that we can develop offerings for that suit them better, that addresses the competition for them, etc. And then exchange. I'm going to explain these all a little more in a moment. So that's actually thinking about what are the benefits? What's in it for me? What do I get out of this if I do the behaviour you want me to do? And we take all of these consumer insights to then come up with the implementation mix. So that's all of those things. If you've ever looked at marketing and, the old school was 4 Ps, so product, price, place, and promotion. But marketing's a whole lot more than that. And that's why we don't call it the marketing mix anymore. It's the implementation mix. So actually thinking about all the other things that we need along with those things. So the people who might deliver the service, the physical evidence, so, where it takes place, and then the processes as well are really important. So when we're thinking about price, it's not just the monetary price, it's the non-monetary price as well, which of course links back to the exchange, the benefits, and sometimes those barriers as well. So it can be, you know, tangible and non-tangible costs. So it might be time, or it might be, you know, that we don't have access to public transport to get somewhere. So we need to be thinking about, what does it actually cost us? Or do we have to take time off work to get somewhere? So thinking about all of those other non-monetary costs. And then promotion, of course, is really important. And as a social marketer, often people misunderstand what social marketing actually is. And with the rise of social media, people think that I work in, well, it used to be Facebook, but now it's all types of social media. That's one tool that we use, but it's not what we do. And promotion isn't all that we do either. So I am not a comms expert or a communications expert. That's probably very low down on my skill set. I understand how to get audience or consumer insights to develop communications, but I'm not great at developing the actual communications. But promotion, however, is really important, because we can come up with the best program or intervention, you know, in the world, really effective in all of our trials. But if nobody knows about it, well, what's the point? So promotion's a really key aspect of social marketing as well, but not the only element. Okay, so let's unpack competition a little bit. So we have to think about the behaviours that our priority group would prefer over the ones that we're actually promoting. So, you know, if we're promoting for people to eat more fruit and vegetables, well, what are they eating, or what would they prefer to eat rather than fruit and vegetables, for example? Or if we are thinking about physical activity, what are the things that they prefer to be doing? Would they prefer to be gaming rather than actually getting out and doing some, you know, going for a walk? Also, the behaviours that they've been doing forever. So, you know, they might have been, well, you might have a piece of white bread toast every morning with Vegemite on it. I have nothing against that. I think that's delicious. But if they're the types of things that people have been doing for a very long time, that's what the competition is. That's what's competing with our behaviour that we would like people to adopt or adapt. And then, as I said before, the organisations and individuals who send messages that counter or oppose the desired behaviour. So, for example, McDonald's or KFC. And I'm sure that you've all got plenty of examples of that and how unhelpful that actually is. So that's also what we're talking about when we're talking about competition. So considering all of these things as we're developing our programs. Hopefully this works. So this is going to take a bit of coordination. So when we're talking about segmentation or personas, we're talking about breaking things down so that we're looking at different groups of people. So not just treating them all as one great big like group. So here we can see Prince Charles and Ozzy Osbourne. May you please click the next. So here we can see, if we were just to break them down by their demographics, they're exactly the same. They're both male. They were both born in 1948. They were both raised in the UK. They've both been married twice. They both live in a castle. Who knew? And they're both wealthy and famous. But do you think that we would develop the same program or the same communications for both of them? Probably not. So personas or segments shouldn't be just about demographics. We need to be thinking about other things. So their values, their challenges, what challenges them? What are they trying to overcome? What are their motivations? What drives them? What's their lifestyle? Now, do you think that Ozzy and Prince Charles have the same lifestyle? Probably not. What about current behaviours? Well, actually, given Ozzy Osbourne's recent health issues, I'm sure that they're probably both being, maybe a little more aligned there now. But you can see that they're very different. But on the surface, they look the same. or, you know, if we just look at their demographics, they're similar, but we need to move beyond that. And when I teach segmentation, or when I used to teach segmentation, I always got all of the students, you know, particularly undergraduate courses, got them to look around the classroom and find one other person in the room that's dressed the same as them. So if we look at demographics, they're all very similar. They might come from different countries, for example, but basically they were aged between 18 and 21. They were all at university, so demographically very similar. But no one ever was dressed exactly the same. As close as we ever got is they might be all wearing black, or wearing, you know, a black outfit. But even then, that was fairly rare. So really important to think beyond just demographics. And I know that that's often our fallback, but we really need to think beyond that, and we'll be more successful if we do. So moving on to exchange. So exchange is really, really important in any behaviour change program, and particularly when we're looking at consumer insights. So really understanding that, what's in it for me. So for an exchange to take place, the priority group has to perceive that the benefits are of equal or greater than the perceived costs. So it has to be better for them to be undertaking the behaviour we want them to be than not doing that. So the benefits are the motivators that get the priority group to act. So really, really important, because we know motivation is a really good driver of behaviour. And they need to be viewed from the consumer's perspective. And this is really, really important, not ours. Now, I know often we base things on our own assumptions, but this is where we really need to listen to people. And I'm going to give you an example of that in a moment as well. And the needs also, the exchange also needs to be valued by our priority group. And you'll notice I say priority group as well. I've really moved away from saying target audience, because that to me says that they're passive. And we need to be, you know, working with people, whether we're researching with them or coming up with interventions, but we need to be working with them. So, you know, researching with them, not at them, or working with them. So really listening to them. And that's, you know, as a marketer, that's key, is actually getting the insights, listening to what people say. And I don't mean just a cursory listen, but really listening to what their needs, their motivations are. You know, what scares them, what stops them from doing things. Really, really important. So I'm going to talk about a case study called My Health for Life. It's a rather large program. The first 4 years of the program, it was received funding from Queensland Health, a funding of $27 million. So really well-funded initiative. And it was it's a lifestyle modification program aiming to reduce the risk of chronic disease in people in their priority group, who were primarily people aged 45 years and over, who had an OSD risk score of 12 and over. And that was adjusted after the first 6 months or so. It started off being OSD risk score of 15 and over, but it was really difficult to get enough people into the program. And the program aimed to complete, and the first iteration, so the first 4 years, aimed to complete 10,000 people through that program and undertake 200,000 risk assessments using the OSD risk or Know Your Numbers prior to that as well. Excuse me. So I led the evaluation of this program for 4 years. So just giving you a little bit of context here. So you can see there all of the reports. There is a link there, and I'm happy to share that link as well. They sit in the Social Marketing Griffith website, publicly accessible. So there's the 4 annual reports there, and then another report that we did called the Environmental Audit Report. Getting mind of it, sorry. That's probably from that slide, because I pulled it in from the time of presentation, sorry. Where we looked at the physical activity and the food environment across 25 postcodes in Queensland, and we also looked at the health services that were available there as well. And that the paper of that's published in the Health Promotion Journal, Australian Health Promotion Journal, if you want to have a look at that as well. So we've done a range of evaluations. So really understanding from the participants' perspective, what are the barriers to behaviour, and those learnings, well, from all of those reports, but particularly from the environmental audit, to teach people or embed strategies into the program to help people to be able to eat healthily and do physical activity, because in some places it's very difficult to access healthy food at a reasonable price. So teaching the participants it's fine, thank you. Other strategies, for example, buying frozen vegetables so that they can still eat healthily when things aren't available at their local supermarket. So this program is run by the Queensland Healthier Alliance, which consists of Diabetes Queensland, who head up the project, Heart Foundation, Stroke Foundation, Ethnic Communities Council of Queensland, Queensland Aboriginal and Islander Health Council, and the 7 PHNs across Queensland as well. Thank you. So we use a quality improvement framework for the program, and where the three places you see the arrows is where consumer insights are embedded or fed back into the program. So at the start or before the program started, so in the planning stage, the market research around the priority groups, and I'll talk to you a little bit about that in a moment, in the design stage as well, and the piloting stage, and then throughout the implementation stage. So I'm going to focus today mostly on the plan and the implementation stage. The design stage, a lot of market research is done every 6 months, so looking at the resources, so all of the materials they use, the delivery of the program, so looking at the quality of the service delivery, the quality of the acceptance of the resources as well, to make improvements on what's actually happening and how the program is being delivered, so that there's that quality improvement across the program delivery as well. So it's moved from a program now into a service delivery stage. So it's, I think, in its 6th year now. Thank you. So just looking at the consumer insights from before the program started, so there were online interviews, caddy interviews, in-person interviews. So the in-person interviews were with people who were Aboriginal and Torres Strait Islander, and then the online interviews and caddy interviews were with people all over Queensland as well, but from the priority group. So people aged 45 years and over. And I don't know what's happened to my slide there, but that did have the total sample, which I think is 1149 or 59. No, it must be 1159 in total. So quite a good sample size. So those consumer insights identified the barriers and enablers for people. And they didn't perceive chronic disease as personally relevant, for example. However, these people were all at risk of developing some sort of chronic disease. The barriers included perceptions of cost of eating healthy, and we know that that's a big issue, time pressures of preparing healthy food or participating in a program, and inconsistent information about diet and exercise. That was a big one as well, that they didn't know who to believe because the information was different everywhere. And, we've been talking today a little bit about, do we have a low carb diet, or, do we do intermittent fasting? There's just so many things. So it's really confusing, and also a lack of motivation. And I don't know if this surprises you or not, but being healthy was not in capital letters, their #1 priority. So whilst that was the assumption going in, that people would readily want to participate in a program like this to become healthy, they didn't really care about that. And, that's probably a reason why they are in the priority group, that they, are at high risk of developing chronic disease. What was important to them was being able to participate in life, being able to be happy. That was their number one priority, and being able to spend time with their friends and family. So whether that was being able to go to the footy club on Friday night to have a beer with their mates, or being able to spend time with their grandchildren, but that was what was really important for them. So when the messaging was developed, that's what they focused on, was being happy. And fortunately, I didn't include the television ad today, because with our technology issues, it would not have worked. But that's what that's based around. It's just about being happy, being able to do the things that you want to do, whether that's going dancing, going fishing, riding your bike, or just hanging out with your family. But that's what was really important. They identified that they wanted something that was personalised as well, or seemed to be personalised. And they also wanted access to health professionals. So they understood that it was really important that if they're going to do something like this, that health professionals, somebody who really knows what they're talking about, is going to be leading the program or helping them. They also wanted it to be free as well, which, you know, sometimes saying, you know, I want something free, then they don't actually use it because it's free. And so it's not really providing that value. So there were some challenges there to overcome, even though the program was going to be free. And they wanted something that was face-to-face as well, which of course through COVID changed, but that was okay. They coped with that. And we did a lot of evaluation around that as well. So if we think back to those marketing tools and dimensions of marketing and thinking about the product or service. So sometimes we say product, but it can, you know, be interchanged with service, and most products have an element of service. So this here is just a snapshot of the website of My Health for Life. But there's a range of resources that are available on the website, and you can do your health check. So you can see that it says start your health check. So that's where you do the AUSD risk. Well, it's a slightly modified AUSD risk, but that's where you do that. But at first, they started calling that the risk assessment. But our consumer insights told us that we needed to remove the word risk, because people that just doesn't resonate, and they don't want to do that because it sounds nasty. And has lots of negative connotations. So they don't want any part of, you know, risk assessment, because they don't recognise that they're actually at risk. So that was changed to health check. And of course, this was all done with lots of consumer testing as well. This whole program was co-designed. So it's all grounded in literature as well. So looked at programs run here in Victoria, the Life program, and also the diabetes program that's run out of Finland as well. And whilst there were insights drawn from both of those programs, the program went away from that a little bit as well, and is underpinned by the health action process approach, which I'll talk about in a little moment as well. So this is what the program looks like, or what they came up with. So it's 6 sessions. So the first session's a one-on-one motivational interview session where they set their intention, really understand what it is that they're trying to get out of the program. Sessions 2, 3, 4, and 5 are 2-hour sessions that are either face-to-face or in a group, which transferred onto Zoom through the COVID lockdown period, or by a one-on-one telephone health coach. And then there's session 6 is 3 months after session 5 as a follow-up and a bit of a check-in as well. And each of those sessions, so 2, 3, 4, and 5, have a different topic each fortnight. So that can be on nutrition, physical activity, other things like sleep, smoking, alcohol, and other lifestyle. But throughout that process, they're also doing all of the elements of the HAPA process. So learning how to set goals, how to make plans, how to make what-if plans if something goes wrong, and then how to check on their progress as well. And then there's the 6-month online follow-up program, which is a self-paced program. And the program is delivered by trained facilitators who are all either GPs or allied health professionals. So they can be nurses, physiotherapists, exercise physiologists, dietitians, but that's part of the criteria for them to actually be able to facilitate the program. And there's a range of different provider organisations, of course, that employ these people to deliver the program. So just some key findings here, just to give you a bit of an idea. And of course, it goes beyond nutrition because it targets physical activity, nutrition, specifically measuring fruit and vegetable consumption, alcohol consumption, sugar sweetened beverage consumption as well. So a range of different diet measures, smoking, and I said alcohol already, didn't I? Yeah, and then also looking at waist circumference and weight. And the reason, and of course, the reason for looking at waist circumference and weight, so not either or, is because of the different groups that the program targets. So it's developed for not only, you know, mainstream groups, but also culturally adapted for 2 Chinese language groups, so Cantonese and Mandarin, Vietnamese, Arabic, and then simple English, which is usable for other language groups, but was specifically developed for Pacific Islanders. So we can see, you know, lots of really good outcomes here from the program as well. So I loosely talked about the consumer insights throughout the program. So that's where some of the things were measured around resources, etc. We also look at, use the data from the there's 3 time points the data is collected throughout the program. So session 1, session 5, and session 6 using repeated measures. And we then looked at or identified segments from that data. So this data is from a smaller group of people who were sampled that did the 6-month follow-up as well. So then we categorize those into different segments based on their responses and their behaviours and what happened using that HAPA model. So we came up with 4 segments here, and we've done this a few different ways as well. But this here is looking at, or divided them into homesteaders, trailblazers, aspirers, and then onlookers as well. And you can see that they're similar in size, but slightly different, but they also are all a little different in their behaviours as well and their outcomes. So we'll just quickly flick through each of these, just so that you can see that they, you know, and this sample, the overall program is much higher in female participants, which they have now addressed, you know, with some specific targeting of males, for example. But we can see that they come from different CIFA quintiles, for example. They have different health quality of life outcomes as well. So if you want to flick to the next one, please. Yeah, so you can see here, this group there's less females in this group, so more males, for example. Next. And then this group here, again, higher in females, but this group, the aspirers, they were the unhealthiest group of all. And they also were the highest group reported the highest incidence of likelihood of mental distress using health-related quality of life measures. Thank you. And then the final group, the onlookers, they were the least likely to have visited their GP recently, so they were the least interested in their health. Hence we call them the onlookers. But they also had the highest level of social disadvantage. So really interesting correlations there as well. So you can see that they're all different. If you want to flip to the next slide. So we used, as I said, a restructured HAPA model. And you can see the different constructs there. If you want to just flip to the next one, please. But we can see that the outcomes, when we model this and look at the different segments, they're all a little bit different. So this insight's really important so that as we move forward in further refining the program, that we can then start to refine the offerings for people as well. By understanding who these people are, we can then tailor some of the offerings. So for some people, they need more help with their self-confidence in food decision-making or food preparation, for example. So we can start to tailor the program or tailor the sessions around that. For other people, they're really confident, so they don't need that help, for example. So by taking this type of approach and breaking it down so that we're grouping people together based on other things besides their demographics, so looking at their behaviours, their attitudes, etc., we can start to really tailor our offerings to help them be successful in our behaviour change programs. And we can see overall from the earlier results that we did have behaviour change across the board, and in some things, you know, showing clinical significance as well, which, you know, as you know, is often hard to achieve in these types of programs. Whilst they all demonstrated significance, some did demonstrate clinical significance. So understanding who these people are, what drives them, or what they need the most support with actually helps them to make those behaviour changes. Thank you. So just quickly, so the difference in psychological predictors of health behaviour change across segments, as we've just seen, and it highlights the utility of taking a segmented approach for behaviour change. So not just a one-size-fits-all, that we really need to listen to people, understand, you know, who they are, what they do, and then tailor our offerings for them, because that will help them be successful. And it really does help us to understand who needs more support as well, or different types of support. And it can also help us to identify those different levels of change that require different behaviour change strategies that can be built into the program. Or it can, and often that can be things that are beyond the individual. So understanding what their context is as well, and what they need help with, because they might need help with knowing which frozen vegetables to purchase or how to prepare them, for example, or even that knowledge piece, understanding that those snap frozen vegetables are as healthy as fresh produce, because often there's misconceptions around that as well. So there's lots of things that we can understand by listening to people and really understanding, you know, their nutrition literacy, their health literacy, their literacy levels, but also that broader context as well. So just really quickly, because I know that we are about out of time, but to understand all of these things, we really need to have a really solid monitoring and evaluation framework in place with those solid metrics to allow us to see those changes throughout the program. So in that, particularly the process evaluation, so that monitoring piece, as well as the evaluation. So looking at the outcomes and what actually happens as a result of the program. So we need to, you know, set solid targets. And, you know, in marketing and business, we love to talk about SMART, and I know that that's something in health we like to use as well. So specific, measurable, achievable, attainable, whichever you like to call it, realistic, and time bound as well. So having those goals and being really specific allows us to measure that change. And then it allows us to take those insights and feed back into our programs as well. So we're using that continual learning and quality improvement cycle and process, which is really, really important. And then, you know, making sure that we're actually reviewing things along the way. So we're not just doing set and forget. We're actually looking along the way at what's working and what's not working and feeding it back into our programs. Next, please. And then just finally, here's just some questions that I like to ask when I'm developing a monitoring and evaluation framework. So are the outcomes truly outcomes and not outputs? So we're not just looking at how many hits on our website or how many people like our Facebook posts. We're looking at what actually happens as a result of our program. And are those outcomes measurable? And whilst this seems to be taking a very quant approach, often we do want to talk to people as well and really understand what's changed for them. Are the outcomes logically connected? So meaning that one can be experienced to lead to another and supported by evidence. So not just taking one thing and saying, yes, this happened, but making sure that we connect those outcomes together as well. Are the outcomes realistic? Are the timeframes for the outcomes achievable? So can we actually expect that type of change in a 12-week period? Or do we need a 12-month period to really see change that's sustainable? And are the outcomes likely to have an effect on the problem in the problem statement? So this is, linking back to that logic model approach or theory of change, whichever way, or, you like to look at things. And I think that's...
Thank you so much. Apologies to Joy and to the audience. I know we're over time, so I really appreciate everybody's attendance, and thanks so much to Victoria Hobbs and Chris Dubala for helping coordinate, and to Joy for talking. We've got a couple of fantastic questions in the chat, so we will endeavour to get Joy to give you some answers after the session. We will let everybody go because we know we're over time, but thanks again, and please join me in thanking Joy for a fantastic presentation. Thank you.